So today we'll be talking about burns, adverse effects, and poisonings. Now, I'll give you a heads up. A lot of people get confused when we talk about adverse effects because that is subdivided into other categories like, you know, if it's a prescribed, like a penicillin is prescribed, but it's underdosed or overdosed, or whether the patient accidentally takes too much of a medication, or the medication is given properly and taken properly, and then you have an adverse effect, et cetera, et cetera. So we'll be spending a lot of time on that, as well as burns. Now, there's a lot of codes that go along with burns, but we have some combo codes, and I think some people are intimidated with coding burns because of the rule of nines. It's a good idea for you to go and memorize the rule of nines. We'll talk about it just a little bit. We're going to highlight it, but there's no graphics, or we didn't put up any specifics per se about rule of nine. So take some time. There's graphics all out there. Google it and commit that to memory. Remember, I will tell you if there's something that you need to memorize versus something that you need to just be aware of. Okay. And this is mostly stuff that you just need to be aware of. But I'd go ahead and commit rule of nines to memory because it's not hard. All right, we're going to get started. Don't forget to have your notebooks out and your ICD CM manuals. We're going to talk about the ICD CM and the PCS, the procedures that are associated to these topics. We're going to start off with coding for burns and corrosions. Now, burns are different than corrosions, all right? When we talk about burns, we're talking about things like thermal burns. That doesn't include sunburns, okay? Some people think of thermal burns as sunburns, but it's actually radiation, okay? Excuse me. And from heat sources. Okay, that's one area. So you got thermal burns, not sunburns, and heat sources. And then you got burns resulting from electricity, electrical burns, and radiation. And actually, sunburns are considered UV radiation. So when you go to look up a sunburn, it's not always easy to find because you don't think radiation. Corrosion is still a burn, but the difference between a corrosion and a burn is that it's chemically induced. Okay, so if you get bleach on your skin and you don't wipe it off, that is a chemical burn, which is corrosion. The three things that you have to know about coding for burns is: one, how deep did the burn go? Two, what's the extent of the burn, meaning how much of the body surface area, and that's something you want to memorize, body surface area, BSA is the way they'll abbreviate that, has been burned. And the agent, meaning was it a corrosion, was it bleach? And that also works with like sunburn. So how deep? Because you can have second degree sunburns because that's where you get blisters. And then the extent, was it all over the body, or was it just, just on the face? And the agent, well, it was a radiation burn. It was the sun. I got a good story to tell you in a little bit about what I did when I was in high school associated to a sunburn. Now, when we talk about burns, it's done in degrees, and you probably are familiar with hearing first degree, second degree, and third degree, but do you know what distinguishes a first degree from a third degree? The first degree is the arrhythmia. I always say this wrong. It's not an arrhythmia, it's erythema. So this is where you have that redness and maybe even a little swelling. Right? That top layer is nice and toasted. Second degree is whenever you have blisters develop. Why does the integumentary system produce the blisters, because whenever you have damage, whether it be an abrasion or anything, you know, that like if you skin your knee, that little white dots of white fluid that comes to the surface of the skin, that is like a serous fluid that is going to lay the groundwork for creating a scab. And that's how the body is getting the white blood cells and everything that it needs to protect itself. Well, that's what happens with a blister. It sends this fluid, this special fluid, to take care of the burn and soothe it, right, and try to start healing it. And it's the blister, it's right under the surface of the skin. Third degree is full thickness involvement. So to understand that, you have to know the layers of the skin, right? So we've gotten through all 3 layers of the skin with full thickness. A lot of times with third degree, you'll see blackness there. Not on all types of burns, but part of it's because the skin dies, you know, and you can have necrosis when it goes that deep as well. But first degree burns and second degree burns, extremely painful. Why? Because it's right there where the nerve endings are. Yeah? But third degree burns, full thickness, not as much pain, because you burnt through the nerve endings. Now that doesn't, but you don't just have all third degree burns. If you have third degree burns, you're going to have second and first degree burns as well. And so that's where the severe pain comes in. If you burn the eyes or internal organs, then they're classified by the location, the anatomy that's involved, and you're not going to have a degree with that. So you don't have third degree burns of your liver, but it's not like you would have that of your liver. We're talking about corrosions that are ingested, the stomach, the esophagus. So you're not going to have third degree burns of the esophagus from a corrosion. All right. With sequencing, now, some people are intimidated with the sequencing, but it's spelled out in your guidelines, all right? The more you practice this, the better you'll get. But note also that in the tabular, when you're dealing with burns, it will tell you code first, code in addition, right? And that tells you the sequencing that's involved. You get better at it with practice, but the first thing that you need to tell yourself is, what is the highest degree of burn? Is it a first degree or a second degree? If it's first and second degree, and mind you, if you have second degree, you'll probably have first degree also. You know, if you have third degree, you're going to have first and second degree as well, most likely, right? So the first thing, what's the highest degree? If the highest degree is second degree burns, that gets sequenced first. Okay, so it's always at the most severe gets sequenced first. That's the way it is with almost everything, right? We always go from the highest and back down. The second thing is we need to know, why is the patient being admitted, right? So is it for the treatment? Then that's going to, of course, be you got to identify the burn that's being treated. A lot of times when you have a burn, you have multiple burns. Even if it's a burn from like scalding of hot water, a lot of this happens to children sometimes. You know, they'll go up and they'll reach a pot of boiling water and dump it on themselves. Grease fires, not necessarily with children, but you know the scenarios, you can think them up. But we don't just have burn in one area. Usually we have it in multiple areas, and the coding is going to take care of that. And we have to tell the story to the highest specificity. So we're going to sequence first the highest degree of burn, right? So if we have second degree burns, let's say, for example, then we have to notate, is there internal and external burns? Now with internal burns, you're going to have that usually with corrosions, right? Chemicals that happen. What is the reason for the admission? That's always going to be your principal diagnosis. Okay. Now, don't get principal diagnosis with the sequencing of first code. Okay, those are kind of two different things. So the sequencing of burns, first code, then telling the story, versus the principal diagnosis, why are they admitted? Okay, now don't get confused there, and we'll give examples of that in a minute. If you have a person who has burn injuries and other related conditions, then again, what is the reason the patient is being admitted? Now, do you remember, if you're following these lectures in sequence or whatever, kind of when we talked about our gentleman that had, he had a diabetic ulcer and pneumonia, and we had to weigh, which was more important, right? And costing, ultimately it boils down to which is more severe, thus which costs the facility more to treat, what more extensive treatment is going to be involved, and the provider is principal in deciding, we're going to query the provider if we don't know. So you have to, again, look at the documentation, and you have to tell yourself, if we have a patient that has burns, but we also have respiratory arrest due to inhalation of smoke, okay, what is the, we could have third-degree burns and respiratory arrest due to the smoke inhalation, which is going to be the principal diagnosis. Why is the patient being, the primary reason? It's going to be not able to breathe, okay? That always gets listed first. And respiratory arrest is different than just being shortness of breath or having difficulty. That means they're not breathing, okay? And if you don't breathe, it doesn't matter if you got third-degree burns. So that's going to be your principal diagnosis. And then you follow the sequencing that involves with burns. Okay. You can have burns of the same local site if you have burns of an extremity. So let's say this is my right hand and I have burns of my right extremity. And when you do rules of nines, when you take time to go look at that, if you don't already know it, then extremities are, this is 9, this is 9, your head's 9, your chest, et cetera, et cetera. Everything's divisible by 9, ultimately, is the way it's divided up. So this whole extremity, if I have multiple burns, like on my hand, my arm, and up here in the upper part of my arm, that is still one site. Okay, that's my upper extremity right side. Now, if I have burns to my upper extremity right side and upper extremity left side, that's 2 separate sites. We have to, if I have second-degree burns to my left side, but I have third-degree burns to my right side, my right side gets listed first because it's the highest degree of burns. If I have second degree and first degree, then this is the highest specificity. We're going to list them both, but the sequencing is always the highest degree of burns. Now, if I have first degree, second degree, and then I have on the thoracic area, I have third degree, then it's listed first, second, and third. Okay, I think you understand that. We have the possibility of having non-healing burns. Then if we have a non-healing burn, you're going to consider this acute because it's not healing. Even though there's a little bit of a time lapse there, it doesn't matter. It's still an acute condition because it's not healing. When you have necrosis of skin, that's death of tissue. And that's very common with burns. And they have to go in and debride that and get rid of that viable tissue or that dying tissue. You could have necrosis of the burned skin. That is should be coded also as non-healed burn. Okay, because it's still not healing. In addition, another thing that's very problematic and very common is infection, infected burn. Then you're going to use an additional code to identify for the infection, but that's an additional code. Okay, so that means that's not going to be sequenced first. So we got to identify that we have a burn. we have a non-healing burn and that there's infection involved. So non-healing burn, and then we're going to wrap up the infection being involved as well. And that's very common because we've just laid open the layers of the skin that protect us, and the immune system is compromised in that area, right? The body can't keep up with the supply and demand of getting rid of your laid open to germs. If you have more than one site, okay, you're going to assign different codes to the different sites. So if I have second-degree burns on my arm, but I have third-degree burns on my chest, then again, those are two separate codes because you code by the anatomy or location, or thus site. Be aware of T30 codes, okay? They are not used very often. Now, I went ahead and put down here at the bottom, I added the T30 through T32. It's burns and corrosions of multiple and unspecified body regions. You're not going to use that T30 code. Make yourself a note in your notebook and go look at that, because I want you to be aware of that. Okay, so take some time just to see those, because you're always going to have specificity with burns. That's how the providers are trained. And now, is there times where we have unspecified body regions? Maybe in the beginning, you know, but if they're inpatient, we're not going to have unspecified. They're going to be identified. Okay, so try to avoid those T30 codes and get to the highest specificity. But it is there for a reason, because sometimes we need to use it. Everything with burns and corrosions are classified to body surface area. So now that's going to give you T31 or T32. So take some time to look at those codes. And this is going to be based on the rule of nines that I told you about. The rule of nines have been around forever. And again, you may have already been exposed to rule of nines and know what they are, but it's not hard to remember. Everything's divided up in divisions of 9. And so if you have, and percentages, but it's not percentages like we think of regular math. If you have one arm is 9 and the other arm is 9 and both of them have burns, then we have 18%, right? Coverage of burn. Now, there is rule of nines, but there is another classification for children. Okay, it's a little higher specificity because for the most part we use rule nines for everybody, but with children you have a smaller, since they're smaller, it is a higher percentage of body surface that that is covered in a burn versus a larger person, right? Their mass is smaller. So take time to look at T31 through T32. Pay attention to those. That's very important. And go ahead and memorize the rule of nines. When we have an appointment for a late effect of burns, then you're going to be identifying that by the 7th character. You know, so we're going to have sequela, late effect. And late effect would be things like scar tissue that builds up that doesn't allow movement of moving body parts like fingers. So when your hand is burnt severely and it builds up scar tissue doesn't have the elasticity that your regular skin has, and therefore you won't be able to maybe articulate those joints as well. It's not that the joints don't work, it's that the skin, it's like wearing a pair of a couple sizes too small pair of jeans. You're not going to get the movement because of the outside layer, right? And that is a sequela. Whenever you use are going to be coding for a sequela of a burn, the 7th character is going to be S. These are late effect codes, and you can also have on a current burn. The 7th character, we could have A for initial encounter, D for subsequent encounter, and S is for late effect. or sequela, which means late effect. If you have external cause codes, just be aware that they're used to just give more specificity, like the intent of the burn. Okay, was it just an accident? I was boiling water and I accidentally, dumped it on myself instead of into the sink because I'm making spaghetti or whatever. Or is it assault because somebody threw a corrosive material at me and burned me? Or is it intentional, where somebody lit themselves on fire? Okay. Now, I don't usually do this, but I wanted you to be aware of the place of occurrence. So I just went ahead and grabbed this out of Find a Code so you could see what the Y92 looked like and the specificity that it's giving you. Normally, I would just say, hey, go look at Y92 and pay attention to it. But I wanted to put this in here so that we could look at it. On Y92, that's going to give you place of occurrence. We need to know statistically where it happened. And the X's that you see on indicate sources and intent, those X's are placement holders because there's not a code for that, but we got to get to more characters to tell the whole story. So don't freak out when you see the X's and say, well, I don't know what the X means. It's just a placement holder. So look at Y92.000. That's the highest specificity we're going to get to. Well, we'll have a seventh character. Kitchen of unspecified, non-institutional or private residence as place. So my kitchen, I was dumping out the spaghetti to drain the spaghetti with the boiling water, and I accidentally tripped and dumped the boiling water and spaghetti on myself. Okay, so where did it happen? It was in the kitchen, a private residence. Now, unspecified, non-institutional, again, this is the Y92, the unspecified is saying, what was the intent? So we've got a dining room, we've got bathroom, bedroom, garden or yard, other place, or unspecified place. Now, other place means that it was identified, but we don't have a code for that. And then unspecified is we don't know where it happened. Okay. But it's a private residence. Okay. So maybe it was the salon, I guess, or the back porch. I don't know. Now we're going to talk about the guidelines that happen with adverse effects, poisonings, underdosing, and toxic effects. Adverse effects is, I took the medication correctly, but I broke out in hives. That's how I think of adverse effect. Poisoning is that I didn't take the medication correctly. Okay, and then underdosing is I didn't take enough of the medication, or well, underdosing, that would be a good example. And then toxic effects, that there was toxicity that was involved. And toxicity is another way of saying poisoning. So we use the table of drugs and chemicals as our index, but we never code from the index. We code from the tabular. Do not pick your code from the index. You go there to find the right code, then you jump over to the tabular to get to the highest specificity and pay attention to the guidelines. The guidelines are all going to surround that code. It's going to tell us if we need additional codes. It's going to tell us if we use this code first in the sequencing, right? And it's going to tell us codes not to use together. It's going to say excludes 1 and 2. So again, cardinal rule, don't code off the index. You code off the tabular. And the table of drugs and chemicals is part of the index, not the tabular. This is the same thing with the neoplasm table. that we've talked about. Sometimes you'll have to use more than one code to tell the whole story, so that's okay. You may end up using more than one. If you have a code that can describe a causative agent for more than one adverse reaction, poison, toxic, et cetera, then you only code the one code. So that, I can't think off the top of my head an example of that, but if one code covers the information, then that's okay. That is fine. But a lot of times you'll end up needing to use more than one code. If you have two or more drugs or medicinal or biological substances that are reported, then you list them separately unless there's a combo code. Now, what does that tell you? That the only reason we've created combo codes is that they happen together commonly. So we would have a combo code. So pay attention to that. It's okay to use combo codes, and you don't code redundantly. So if you have a combo code, you're not going to code in addition unless it tells you to code into it in addition. Now that's the exception. You will not get this information from the index, the table of drugs and chemicals. All of those information and guidelines, code in addition is all in the tabular. That's why you've got to go there. But you will see combo codes listed in the index, the table. And then you jump to the tabular to verify. When we have drug toxicity, that's like a poisoning. So we can have adverse effects. These are going to be T codes. And, what you're going to do is look at just go to the T codes and peruse them in the tabular to see what is actually available to you. So when you have a drug and it was correctly prescribed and properly administered, but we had an effect, then you're going to use one of these T codes to explain that. So an example of that would be, I was prescribed penicillin. I was given the correct dose, I took the correct dose, and I broke out in hives. That's an adverse effect. A poisoning is different, because a poisoning is, or it could be, a poisoning is also a reaction. And the key here is that it's improper use of a medication. Okay, so improper use of a medication would be taking too much of the medication. Let's say I was prescribed the proper dose of the penicillin, but I just got in my head that I don't want to have to take it for 7 days. I'll just take it all at once. And then I got it killed all the good bacteria in my stomach and intestines, and I was very, very sick. So that is properly prescribed, but taken incorrectly, improperly, and I had an adverse effect. I poisoned myself. Okay, you will use the codes from T36 through T50. So turn to your tabular and look at T36 through T50 and just look at the possibilities. Just peruse them so that you can be familiar with what you'd be dealing with. When we talk about poisonings, we need to know what the intent was. And the intents are always going to be either accidental. Now, I think I've told you stories of when I had kidney stones. Now I do not allow myself to give myself my pain pills, because I get time messed up when I take a pain pill, at least the ones that they give me, and I can't comprehend if it's been 2 hours, 4 hours, or 6 hours. It gets wonky in my brain. So I give it to my husband and I said, when can I take my next pill? And he'll say, well, you can't have one before 4 o'clock. Well, even if you tell me that, I won't remember 4 o'clock. And so 2 hours later, I'll say, can I have another pill? No, you've got to wait 2 more hours, and I make him give it to me. Now that doesn't happen very often, but needless to say, when you've got a kidney stone, you're not thinking clearly. If I were to give myself a pain pill and then 2 hours take another pain pill when I'm not supposed to take one for 6, and then I take 2 more in another 2 hours instead of waiting the 6, I could have accidentally poisoned myself, right? So again, accidental. I wasn't intending to harm myself. It was an accident. Now, intentional self-harm would be if I just took the whole bottle and I decided to take them all at once. Assault would be if somebody gave me, if I asked for a Tylenol, a couple Tylenol, and they gave me a couple, Darvocet instead. Again, that or overdosed you on a pain medication or something instead. That's an assault. Other assaults would be there. One of the textbook that we had at the college, I remember, was so funny because it was an outlandish scenario in my opinion, but they had spiked somebody's drink. They asked you to code having spiked somebody's drink with snake venom. Now, that is really thinking outside the box, but I guess it's been done before. So I just pictured in my head going to a nightclub or a bar and somebody putting, rattlesnake venom in your beer or in your scotch, and you drink that down. Well, of course that would poison you. That's assault. Okay. That's what they wanted to know if you understood. Undetermined means we just don't know the intention. Okay, so if I end up in the ER because I took too much of my pain medication, they don't know. Was it accidental? If I'm unconscious, did I do it on purpose, or did somebody, do that to me? We don't know. It's undetermined. And so that is not an unspecified. That's meaning we just don't know the scenario. We don't have enough information. So that's okay. Notice I went ahead and put that adverse effect. I pulled this code T36.0, poisoning by adverse effect of underdosing of penicillin. So again, this is using the term poisoning and adverse effect, but it's for underdosing of penicillin. Now we don't think of that as in combinations together, but there's a code for that, and there's a code for a reason. All right. So pay attention to those T codes, go look those up and do a little light reading for those. Now let's talk about poisonings and the sequencing that may be involved. If we have a poisoning, we may have manifestations of that poisoning. And so therefore we need to use additional codes to identify that. Now that means whenever you see use additional codes, that means they're going to be sequenced after it. So if a person has had a poisoning, which is, remember, we have intentional assault, accidental or whatever, and let's say they're unconscious and we can't wake them up because they took too many of their pain pills unintentionally. So what's the manifestation of that? A level of consciousness, right? So that's the manifestation. And you may have suppressed breathing. You could have respiratory arrest do that because pain pills are suppressants, right? And so you could develop respiratory arrest. So we're going to use that as an additional. Abuse or dependence can also be identified in poisonings. So if you have a person who is a heroin addict, they are abusing it and they've poisoned themselves. They've overdosed on heroin. Some examples of poisonings that to just kind of help you think outside the box if you've not been exposed to these. Error was made in a prescription. So let's say that, when a lot of prescriptions are based on weight. And if they don't pay attention to the weight of the patient, then you may prescribe them a higher dose than they need, right? So that would be like giving a child a pain pill prescription dose for an adult. That would be an error in the prescription. Overdose of a drug intentionally taken. Okay, that would be, again, taking medication to off yourself, I guess. Non-prescribed drug taken with correctly prescribed and properly administered drug. So a non-prescribed drug taken, think of St. John's wort. St. John's wort is a mood medication. People who, it's over the counter, it's like a herb, and people will take St. John's wort to help them feel better and have a better mood, and it works very well for people who are having little depression symptoms or something, you know. The problem is that it's also a blood thinner, and people don't know that. So you don't take too much of it because you think it's natural. So you think, oh, wow, this made me feel really good. I'm going to take 3 instead of 1. Well, it's a blood thinner. Okay, that would be poisoning yourself with an over-the-counter medication unintentionally. But what if you were also on Coumadin? And this has happened, unfortunately, more times than I'd care to mention. But you don't tell your provider that you're taking over-the-counter medications, all right? And you know that it's for your mood. So what does it have to do with your blood, right? And you're prescribed Coumadin because you have a, I don't know, an arrhythmia or something. I don't know, for whatever reason. And you're taking them together and you bleed out. You start having internal bleeding. You start having maybe having blood in your stomach or your stools. So that is taking a non-prescribed drug because it's over the counter, and you're taking it with correctly prescribed Coumadin, and you're so the prescription was correct and you're taking it correctly, the Coumadin, but it is going to poison you because they're both blood thinners. Interaction of drugs and alcohol. Now, this is something that some people think, well, I can take a pain pill, but I know what'll make me relax. I'm going to go have a hot toddy, right? No, you don't take alcohol with pain medications, because alcohol is also a suppressant, and pain medications is a suppressant. And next thing you know, you're not breathing, right? Okay. Underdosing is going to be taking less of the medication prescribed. Oh, well, I don't want to take as many pills as he tells me because I want to save some of those antibiotics if I get sick again. No, that's underdosing. Should never be assigned as a principal diagnosis, so keep that in mind. But think about non-compliance or complications being used with underdosing. So it's intent. So if you're non-compliant, I got this prescription for 14 days of penicillin because I have a kidney infection, and usually get more days, 7 days is usually what you get with an antibiotic, but you get 14 if you have a kidney infection versus a bladder infection usually. So I'm going to just take 7 days and keep the rest for the next time I have an infection, because I don't want to have to go to the doctor again. I can self-diagnose myself, right? No, that's being non-compliant. Right. Toxic effect is when you ingest or come in contact with a harmful substance. And with that, again, you need intent. Was it accidental, intentional self-harm, or assault? Which we've already talked about those, so they make sense to us. You may not have thought about abuse, adult and child abuse, being in this category, but it is. So we have adult abuse, child abuse, neglect, and maltreatment. Again, we think of child abuse, that's common, but we don't think of adult abuse, and that is things like spousal abuse. And don't think that this is just exclusive for women. Men can be abused as well. And we have to think of the elderly. This is something that's tracked very heavily for adult abuse and of the elderly. In fact, there's state and federal organizations that track this. So when we have abuse of any kind, neglect or maltreatment, you're going to sequence first with the code for abuse. Now, we need this for statistical purposes. as well as plan of care for the patient and medical decision making. So if you have when you're going to code that first, but then if you have any mental health or injury codes, then that's going to go sequence after that. So your first sequence code is, we have, adult abuse, and then the second code is that, the wife was punched and has a broken jaw. Okay, or a broken arm, something like that. So what happened? We have adult abuse, and then what was the result of that? A fracture. If you have this stated in the documentation, you only code it if it's confirmed. So if we have suspected child abuse, you do not code that. It has to be confirmed to be able to code that. That's the same as giving somebody diabetes without them having diabetes, because this will follow them. Be very careful with that. With confirmed abuse, then you're going to also use a cause or a code from the assault section to identify the physical injuries, and the codes for suspected abuse or rule out abuse are going to be these Z codes. Look at Z04.71 or Z04.72. Now that is suspected. That's not confirmation. That's saying, hey, we need to statistically put in here, and we also need for plan of care that we suspect something is up. Okay. The guidelines for abuse for child and adult is maltreatment, and they're classified as assault. Okay. And again, we don't think of assault sometimes in the terms of like this, because we think that abuse is not synonymous with anything else, right? Abuse is just abuse. No, it's actually assault. So that's how you classify it. In addition, we need any external cause of injury, okay, resulting from confirmed abuse. And then for the confirmed cases, there's a code for the perpetrator, should accompany any other assault codes. Now we're going to look at the various types of burns and adverse effects and coding. And this is some of this is going to be just a little bit redundant. We're going to talk again about some of the things that we already mentioned, but the anatomy and physiology of it. You can have injuries all over the body, of course, so the entire body can be involved in injuries, right? When that happens, then you're going to go to that particular body system. So if we have an injury for a caustic burn to the arm, well, then we're going to be coding for the burn, but we're also going to be coding codes in the integumentary system, right? If we have a caustic ingestion of a chemical, then the digestive system is going to be involved, right? So think of it that way. With burns themselves, the conditions that we should be aware of is, again, highest degree of burn gets sequenced first. When you have a degree of burns for one site, you're going to always the highest degree will always trump everything else. So like I mentioned, the right arm, so right upper extremity, if you have third degree, second degree burns, you're only going to use one code for third degree burns. You're not going to code second degree burns at that extremity and third degree burns. Now, this is classic test questions, guys. You will be tested on understanding that for one site, if you have more than 1 degree of burn, you only use the one code for the highest specificity, okay? So, and it's very common in real life to have several degrees of burns in one particular area. And then the reason it's coding for burns can be complex is that usually burns don't happen in just one area. You have burns all over the body, depending on the reason. Like if you were in a house fire, you possibly could have burns all over your body versus even dumping something hot on you or ingesting something toxic or caustic. You're going to have burns to the mouth, esophagus, and stomach. And if it keeps going through, it's going to get into the intestines, right? And just so you know, when poison control, when you ingest a corrosive material, they don't want you throwing that up. They let your body dilute. You take something to dilute it and let it run through. Because if you bring it back up, then it's going to make even more severe burns, burn the area that's already burnt. Okay, so they'll make you ingest something to dilute it and counteract it, and then let it pass through the body, hopefully diluting it enough so that it doesn't burn all the way out. Just a little note for you. Non-healing burns, again, are acute. We already talked about that. And pay attention to sequelas, late effects. The burn categories are going to be T31 and T32. We need to know the total body surface area and that rule of nines. Here is just a quick overview of the rule of nines that I want you to take some time and go study on your own. Okay, it's your responsibility to know that. Rule of nines, they divide the head and neck up. Each arm is 9. Each leg is 18. Why? Because the leg is more body surface area than arms, so it makes sense, right? And anterior trunk and posterior trunk, meaning the front and the back of the body, is 18, and genitalia gets 1%. So if we have a burn to the head and neck and one arm, then we have an 18% burn, right? If we have a each arm and the genitalia, or let's say we have the anterior trunk and genitalia, then it's 19% because it's 18 plus the 1%. Okay. Again, lots of great information about rules of nines, and there's not really a lot of math involved. You can do divisibles of 9. Oh, great question that just came through, by the way. Tony asked, do we code for debridement of burned tissue? These are going to be procedure codes, so we'll get to that at the end when we do PCS. Okay, because yeah, you do. So frostbite, did you think about frostbite being a burn? Well, actually, it is. It's because think of cryo, right? The frostbite reacts, the tissue reacts just like being burned. So the underlying tissue can freeze due to extreme cold. There are actually, though, 4 degrees of frostbite. So frostbite, the first degree is only affecting the skin surface, and we don't have any permanent damage. And this is actually pretty common. So when you get out there and you stay too long out in the cold, or you don't have your face, and your cheeks are really roughened up and cold and red, and you can't feel, it's numb and stuff, that's really like a 1st degree frostbite. And wind burn can do that with the cold, so you got to keep everything covered up. 2nd degree, you get blisters, and the tissue becomes hard and sometimes can turn black. That's 2nd degree. Why would the body produce blisters with this? Because it's a burn. So the skin is going to react just like it does if you have a burn from heat. Okay. 3rd and 4th degree goes deep, can go into the muscle, the tendons, and kill off the nerves. You usually, not always, but that tissue gets necrotic a lot of times, and it has to be debrided or cut out. You can get gangrene and amputations involved. So just because it turns black Doesn't mean we have third and fourth degree, but if you have third and fourth degree, yeah, it's going to be black. And the people that I've seen, or you can go out and Google image and stuff, frostbite, mountain climbers is who I always think of. Their noses, and they can lose fingers and toes. Okay. Now reiterating our poisonings, and with adverse effect, it's a pathological manifestation due to ingestion or exposure to drug or chemical substance. That's really your definition. And we need to know what the side effect or the reaction to the drug, and be very careful whether it's a prescription, and don't overlook OTC or over-the-counter medications. That's what OTC stands for, if you didn't know. Table of drugs and chemicals will give you that initial where where to go in the tabular. T36 through T50, you've already made a note of that, and you're going to go peruse that for a little light reading of the tabular, correct? Note that medications, drugs have generic and brand names. So don't get confused with those. If you don't know if a generic name is listed in the documentation, and it's in listed in the drugs of chemicals and stuff. For example, do you know all the drugs that are considered opioids? Do you have to have those memorized? No. The more you deal with them, but opioids isn't something we necessarily deal with as much. So when you go and you look at those, you'll be able to go to things like drugs.com, and it'll say whether it's an opioid or not. Okay. Generic names, things like, let's see, antihypertensive, anti-anginal, or anginal, meaning you have chest pain, and adenoplastic, which it's really anti-neoplastic, meaning cancer drugs and stuff. Manifestation codes are sequenced before the adverse effect T code. So what's the manifestation, and then what's the adverse effect? Okay. When you have abnormal lab reports that will be associated with adverse effects, you could have like abnormal dilantin level in the blood. That's a good example. The patient's drug dosage is changed, but the patient doesn't have any other manifestation. So again, the seventh character is going to distinguish this. And they do this with a lot of different medications. So the patient's taking the medication correctly, it was prescribed correctly, they do some blood tests, and they're like, oh, okay, now we have a buildup, or the dilantin level's too high, let's back off the dose, and then the patient isn't having any ill effects. They just did a lab. It's like, oh, okay, our levels. And there are some medications like medications for your thyroid that there isn't a sequence for it. We don't know that, oh, if you weigh 200 pounds and you're an adult male, that and your level is X for your thyroid, you have hyperthyroid disorder, then we know to give you Y milligrams and dose. Like they don't do that. We have to start you out at a base dose of what they think is going to work, and then it takes time to regulate that. That's one of the only medications that are like that. So you go in and a lot of times have labs done, and then they, what type of manifestations are you having, or are you feeling better, are you doing this, are you doing that, are you able to sleep, blah 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 blah, and then they tweak the dose, and it can take a year or two to get the proper dose, and then something can happen and they got to tweak it again. I had a good friend of mine that had hypothyroidism, and whenever she got pregnant, just when everything was going fine, that she would get pregnant and all of her doses would go crazy, and she would know because of the signs and symptoms of her condition. She wouldn't be able to sleep. All these things would happen. She'd go back to the doctor, and sure enough, her levels were off, and they'd have to start redosing her. Anyway, so that's interesting. So adverse effect, abnormal labs, just be careful of that. Now, underdosing, when you're taking less medication, you're going to, again, code the medical condition first, then the underdosing, and explain the reason for the underdosing. You know, maybe the person gained weight, right? No, the underdosing happens with my son that has epilepsy. So now at this present time, he's 14. Well, what happens to 14-year-old boys between 14 and 18 years old? Psh, they shoot up, right? And so his epilepsy medication, every year we have to go in, he'll start having seizures again, and we know everything's going along just fine, and then bam, he starts having breakthrough seizures or seizures, and we realize, hey, it's time to go in and have his levels checked, which they do via lab tests, and say, yeah, he's not got enough of it in his system. Poisonings, what happens? We're just reiterating. Patient takes a wrong medication, not correctly or currently prescribed, wrong dose is taken. They take a double the dose, and again, this happens so often, and it's now, when I say it's the ignorance of the patient, when I use the term ignorance, I mean lack of knowledge. They just don't understand how the medication works, or being naive maybe is a more kind way of saying it. That, you know, the patient thinks that it's okay to take 4 Tylenol, extra strength Tylenol, instead of 2, because they're in a lot of pain. And then they do that every 2 hours instead of every 4 to 6 hours, like the bottle says. It's over the counter, so it shouldn't hurt me, right? And then next thing you know, their liver is shutting down, in their kidneys, because Tylenol, actually, acetaminophen, is extremely dangerous. If you get it in large doses, it'll damage the liver. And we don't think of that because it's over the counter. We think it's perfectly safe. Whereas acetaminophen is Tylenol. Whereas with ibuprofen, you know, like Advil and stuff, it will eat up your stomach if you overdose that. So, okay, so overdose, again, of over-the-counter medications can happen in non-prescribed or alcohol interactions, which we've already kind of talked about that. We always sequence first the poisoning T code, and they follow accidental self-harm, intentional self-harm, assault, and undetermined. We talked about that. Toxic effects of substances that are non-medicinal as the source. So there are all kinds of substances that can give you a toxic reaction. They could be mild to life-threatening, which I already told you about St. John's wort. Everybody thinks it's natural and it's okay, and it has to do with your mood. That's what it's prescribed for. But, you know, it's very dangerous, because if you use it in combination with other things, like, did you even know that ibuprofen is a blood thinner? So we think of it as an anti-inflammatory, and it is. But why do you think they tell you not to take any ibuprofen before you go in and have a surgery? Because it thins the blood. Now, what happens if you take ibuprofen for your muscle aches and pains, and you take St. John's wort, and you take too much of it? What happens if you take ibuprofen, St. John's wort, and Coumadin? Now, again, ibuprofen and St. John's wort over the counter, how safe can that be, right? But they add that with Coumadin. Next thing you know, you're puking up coffee grounds, which is what happens. Blood in the stomach looks like coffee grounds when it comes up. All right, so there's instructions at the beginning of that area about toxicity and stuff that you should go over. Let's see, other unspecified external causes would be things like radiation, temperature, heat and light, and air pressure can all affect the body. Okay, external causes. We talked about adult and child abuse. This stuff is statistically captured, and providers are required to report abuse. So the major types are physical abuse, somebody punched somebody else in the nose, sexual abuse, emotional and psychological abuse, which can be overlooked a lot, neglect or abandonment. This happens with children, but it happens a lot with the elderly. Now, if you watch some YouTube videos with one of the ones I started watching is the Tobro, I think his name is. He's a Canadian, and he is a podiatrist. And there's a couple other ones. One I think is called the Foot Doctor. I think he may be in LA or Las Vegas or something. But they will have a patient come in, an elderly person, and their toenails will be like this long, and they don't just grow out straight, but they'll start laying over and curling in and cutting into each other and stuff. Now, if the patient, if the elderly person is living on their own and nobody knows about this, that's not neglect or abandonment. But if somebody is responsible for their care and that happens, especially if they were a diabetic, can you imagine having a toenail come in and grow into another part of the foot? That's neglect and abandonment. Okay, it's one thing if the person is neglecting their own feet, that's, but if you're responsible for taking care of the well-being of that elderly person and you don't go in and either clip their toenails or take care of their toenails, then you can have a mess. And I've seen some really bad cases. Just even bathing. Elderly people don't necessarily think about bathing as much. Now, I'm not saying that they don't. I'm just saying that, they're not up moving around, and sometimes you'll have elderly patients working in skilled facilities. As when I was younger, I always thought they never liked taking a bath, but if you're responsible for that person and you don't ever have them take a bath, or they don't, take a bath, then you're going to have breakdown of skin, right? Okay, so that could be neglect or abandonment. The same thing would happen with children. Let's talk about CSRS real quick. That's a medical condition due to an infection or non-infection cause, such as AIDS. You could have cancer, pancreatitis, or trauma that could happen. And we've done, there's another area, another lecture that talks about CSRS in more depth. But when that happens, then we're going to have adverse effects and manifestations, and you're going to always code the underlying condition first in those examples. If you have a person with trauma, then the severe injury is the principal diagnosis, with CSRS as a secondary diagnosis. So that's an exception to that. Now, I went and looked before we came together today to make sure that I was pronouncing this word correctly, and I was, but this is called rhabdomyolysis. And what happens is the muscle fibers, your muscles break down, and it release a muscle fiber content into the circulation. This is relatively rare, but what happens is the reasons this could happen is you have too much muscle exertion. So people who are bodybuilders, or the people that do weight training, like strongman competitions. I can't remember what that's called. Weight. It's not weightlifting. It's something else. Or like a marathon runner, right? A triathlon. That muscles could start breaking down. Trauma or crush injuries. Muscle ischemia, meaning there's a disease of the muscle already, and we have arterial occlusion or insufficiency with the blood supply. Burns, this happens with burns. Repetitive muscle injury. So you've heard of people saying, hey, you can't do this anymore because your muscles are too torn up. You're going to injure yourself. So this happens to athletes a lot. And they say, you're done. This career is done. Status epilepticus will do this because they spill. Whenever you have a seizure, think about it. It's like running a marathon, because the muscles are are being electrically charged, you know, it's based on the nerves, the electrical current. But if you've ever seen anybody have a seizure, they have repetitive muscle movements. Now, even if it lasts 5 to 6 minutes, think of doing a marathon in 5 to 6 minutes, right? And so after a seizure, you usually have pulled muscles. And like my son, can you imagine when he was having seizures that would last an hour? Can you imagine? His muscles were so sore for several days after that. Drug overdose will do this, as well as extended periods of muscle pressure. Oh, it didn't click. Late effects of injuries, again, residual effects may need treatment, but look at Chapter 5 for coding late effects. So you could have late effects at any time from anything like burns or poisoning, stuff like that. So if a person overdoses on Tylenol and it messes with their liver, that's going to be a late effect. Any problems that you know, you could destroy your kidneys by taking medications or something, or some type of toxicity. The 7th character is going to be S for sequela, and you're going to want to identify what the late effect is. Whenever you have 2 codes with the sequela, that's sequenced first, and that 7th character, you could use a K. And this is unique because it's used to talk about encounters for fractures with non-union. But that's the only time you're going to see that 7th character of K. That's unique. So now let's talk about some Z codes that are common. There's a lot of them that go over what we've talked about. One, and you don't know to code these if you don't know they exist, right? So personal history of allergy to medication agents. So if you're allergic to penicillin, right, then you're going to get a Z code for that. Or allergy to other medicinal agents. And again, that means it's not, you got a personal history of an allergy and allergy other, let's see, other than to medicinal agents. I said that wrong. History of physical abuse. So if you have a child that, or an adult or an elderly person that has been physically abused, then that carries a Z code. Emotional abuse as well. History of an injury. History of a poisoning. Exposure to, so someone that's been, for example, exposed to HIV. Counseling for physical abuse. Observation following an alleged rape or seduction, observation following other inflicted injury, and observation and evaluation. So common treatments, we'll go over those, and we're going to talk about some pain medication, anti-inflammatories. Corticosteroids are often used in antibiotics. Well, I'm sorry, we're not going to talk about those. Those were the ones that are commonly used. Now we're going to talk about procedures, and Tony had asked about debridement. So if you go in and you debride, then that is considered the root operation of excision. When you do PCS, the root operation is the hardest part to get. So debridement, excisional debridement is excision, is the 3rd character, root operation. Now, if it's non-excisional debridement, then it's an extraction. Okay, so make a note of those. Excisional, we're going to cut away. Debridement, 3rd character is excision, and non-excisional debridement is extraction. Whenever we have debridements, it can be done over a period of time, and you can have different providers that do it. So if you do it at a hospital, and but at bedside, then that's going to be distinguished in your code choice. You do, let's see, it says you do not have to be done in the OR. Sometimes they'll do debridements in the bedside. But if you are, something that you may not realize is that physical therapists and wound care nurses will do debridement. Did you know physical therapists could do this? When I was doing home health, we had this amazing physical therapist, and she was a wound care specialist. And you don't think necessarily. You think of that of, oh, we got to, be able to move this arm or whatever. But she was really good, and the nurses were always calling in her to work with a patient that had a wound, and she was fabulous. And so anyway, that is something that you could see documentation from a physical therapist on wound care. If you have never experienced seeing a hyperbaric oxygen therapy or a hyperbaric chamber, that's pretty cool. That's a specialty type of medicine that deals mostly, not exclusively with wound care, but hyperbaric medicine, a lot of the hospitals will have, or wound care facilities will have hyperbaric chambers, not just one, multiple. And when I lived in another area of Texas, there were both, I think one of the hospitals there had a hyperbaric department, and we got to go through our coding group got to go through there and talk with the doctor, and he gave us a tour and talked about some really amazing things that they did. There are certain conditions, certain poisonings that react very good to hyperbaric oxygen therapy, and other ones don't. Now, I can't remember some of the details, but for example, I think there was and I could be telling you wrong, so take this with a grain of salt, but if you had like this particular snake bite, let's just say rattlesnake bite, it reacted really, really well to hyperbaric chamber treatments, versus like a black widow bite didn't. The oxygen infused into the tissue made it worse. And so again, they studied and they knew all of this stuff, and it was pretty interesting to listen to. So I had a friend that had to go through hyperbaric treatment because she had fractured her ankle and had to have surgery, and that part of the ankle was so thin, the tissue, it wasn't healing very well, and so she ended up having to go through hyperbaric treatment, and that helped. It is a different type of medicine, very exciting, and if you are interested in that, do a little more study about that. So what happens with hyperbaric treatments in a hyperbaric chamber? You have to take off all your jewelry, no makeup, nothing and everything. You get put into this tube, this chamber. They seal it up, it's airtight, and then they increase the atmospheric pressure. So your ears pop, and what it does is then they put in oxygen, okay? And it doesn't go through the bloodstream, it gets infused into the tissue. That's why it's different. It helps with healing, and can also get rid of some of the poisonings. It's really good in air and gas embolisms. Now, of course, we know that. So like divers, they always have a hyperbaric chamber available when you have people that do deep sea diving. Decompression sickness for the divers. Burns and other wounds react really well with this oxygenation. Carbon monoxide poisoning, that's how they treat it. And smoke inhalation, it works really well with them, to name a few. So it's pretty exciting. And that wraps it up. I didn't tell you my story for my burn. I'll just real quickly tell you after I read this quote. No matter what fabulous place I visit, I don't feel like I'm on a vacation unless I'm dehydrated and covered with sunscreen. And that was from Chelsea Kane, which is an author. But I thought that was really cute. That was funny. So my real quick story is that when I was a teenager, my friend and I we grew up in a resort town. So we went to this one resort, and you could pay like $5 or $10 and use their facilities. And we decided we were going to use their sun lamp, because tanning beds were a big thing back then. But this was a sun lamp, not a tanning bed. That's different. It's a different type of light. And the guy had told us, don't do more than 5 minutes on each side. So it was a lamp, and you just got your bathing suit on and you stood in front of it, and then you just rocked yourself in front of the lamp, and then you turn around and do 5 minutes on each side. Well, we decided that if 5 minutes was good, we should do 10, 15, because we couldn't tell that it did anything. Well, we both burnt ourselves very severely, so second-degree burns. I think she was worse than I was, and it was really bad. We probably should have gone and gotten treatment for it. But within so we went and took showers afterwards, and then we thought, "Whew, my skin's kind of tight." Both of us. By the time we got home, her face was swollen. We had swelling and red, and I had to take my driver's test like 4 days later, and I was burnt so bad. Worst sunburn I've ever had. Anyway, that's my story. So thank you for joining us. Don't forget to like and subscribe if you're watching us on YouTube or Facebook. But any questions that you have, go out to the CCO Club and ask your questions there. Any experiences that you want to share, or if you need more detail on anything, maybe you want to go and share the worst sunburn you've ever had. That would be great. All right. Thanks, guys. Bye-bye.